This is Brian Wormers recording a lecture for Intraoperative Nursing for Medical Surgical Nursing. Here are your learning objectives. Some of the members of the surgical team are going to include, of course, the surgeon and any surgical assistant that they might have, either a PA or a nurse or a scrub tech. There's an anesthesia in the room. This can include physician-based anesthesiologists or CRNAs. This can also be holding area nurses. This can be circulating operating room nurse. This can be a scrub nurse who's helping out at the bedside. Surge techs, which we talked about before. There might be some specialty nurses in there if they're working with specialized equipment such as defibrillators or pain pumps, and there might be some specialists that are used in addition to nursing staff. Oftentimes we are using minimally invasive surgery anymore, and this has become common practice. So we've got one that goes in and we get different tools. We've got a laparoscope, which often is your insufflation as well. So you've got gas running through that to open up the abdominal cavity, and that makes it easier to work on. So common things that we do, cholecystectomy points, starting to even do more cardiac surgeries now. We can take out spleens, and some spinal surgery is being more minimally invasive. Potential injury to this, you can have mechanical trauma of having those probes in there. And then also we have to worry about thermal injuries. And this can be heat from cauterization. It is theoretically possible that you can start a fire too inside of a person's body. So those are things to watch for. The environment of the operating room, this is a surgical place, so then we want this nice and clean. We want this laid out in a nice and orderly fashion. We need health and hygiene of all the surgical teams, so if you're sick, we don't want you in there. And then surgical attire. So anybody that's working on the patient during surgery, they have to have gowns, gloves, surgical masks, all those things. If you're just in there as a circulating nurse or part of anesthesia, generally speaking, you need the hat and scrubs, but you do not have to wear the sterile gowns and sterile gloves. We have to remember that people are a source of bacteria in the surgical setting, so we try to limit that. And then we talked about the dress that's needed with that. So here's a picture of how to scrub up and gown up. We covered this in class earlier on. For anesthesia, we're trying to induce a state of partial or total loss of sensation so they don't feel the surgery. This can occur with or without loss of consciousness. We can use nerve blocks in trying to decrease nerve impulse and transmission, suppress reflexes, and cause some muscle relaxation. Variety of different meds and ways that we can do this based on patient history and situation that you're going to be in. General anesthetic, so this is reversible loss of consciousness induced by inhibiting neuronal impulses of several areas of the nervous system. This can involve single or combination of agents. Most of the time I've seen it as a combination. This can depress your CNS, causing analgesia, amnesia, and unconsciousness. This can be given by inhalation, IV, or a combination of the above. A lot of times we do give adjuncts to this called hypnotics or opioid analgesics or neuromuscular blocking agents to try and paralyze them. 4 different stages of general anesthesia, so we can give analgesia and sedation to relax them. They can have a little bit of excitement and delirium, and then it progresses on to operative anesthesia and surgical anesthesia. Stage 4 is a little deep. We don't want to go to that phase. And then we can go into emergence once we're done and recover them from anesthesia. Complications could be malignant hyperthermia, and this is a big one we're going to talk about some bed. You can talk about overdose of some of the medications. We can talk about hypoventilation if we're not ventilating correctly, we can paralyze them. And then we can have problems with the medication. So malignant hyperthermia, this is a big issue. This is acute life-threatening complication that still happens to this day. This tends to be a genetic thing and have familial traits. What happens is you give a particular sedative and anesthesia agent, and this leads into skeletal muscles firing and becoming or working a little bit harder, leads to acidosis, causes high temperatures and dyspneas. The treatment for this is naturally, but if you look right here, here's a great website if you're more curious about this topic. Clinical manifestations of malignant hyperthermia will include tachycardia, modeling, cyanosis, myoglobinuria, so you're getting breakdown and it's coming out through the urine. You're going to get a rise in your end-tidal, and then you're going to see an elevated. You can give some local anesthesia for some surgery. This is going to disrupt a region or a particular part, and you're usually given this by local infiltration. So if you think about the lidocaine before an IV stick, that's local anesthetic. Can give regional blocks. We can either block a field, specific nervous tract, the spinal, or an epidural. I'm sure you guys have heard of spinal before, or epidurals before. So for prepping them for the spinal or epidural anesthesia, we can look at this where we're going to put the needle in. We're looking at the lumbar spine region. We get them bent over until it widens out the vertebrae so we get a better approach. And then we insert into that space. Complications, well, if they have a reaction to the medicine that we're giving, they can have anaphylaxis. This can have some systemic absorption, so we can see that the effects go far beyond what we want. We can do an overdose from this, where they have a longer reaction to this than what we want, or we can have some local complications, as well as so having some bleeding or some of those kind of issues. So treatment of complications is generally the same. We're talking about ABC, so establishing airway, giving oxygen. We do want to notify the surgeon and anesthesiologist if we're having complications. And then epinephrine is one of those drugs I want you to be aware of in case they have bradycardia. For moderate or conscious sedation, we're given sedatives and hypnotics to reduce the level of consciousness, but they're still able to follow verbal commands. Things that we want with this, sometimes they can protect their airway, and generally speaking, we don't have any side effects with this. It does cause amnesia, but the patient is able to return to ADLs a lot faster than with general. Some of these meds would include etomidate, propofol, diazepam, lorazepam, Versed, Demerol, fentanyl. So the list goes on and on. Collaborative management of the patient during conscious sedation procedure is very similar to surgery. We're doing identification of that patient, we're doing consent, we're doing a timeout, and we're making sure we've got the correct therapy during that procedure. We do want to do a medical review prior to, including advanced directives, DNR orders, looking for any allergies or side effects that we need to be aware of. We're looking about blood transfusions if they've had any previous autologous donation. We need to look at any laboratory diagnostic test results, and then of course medical history and physical exam findings. We can place them into a variety of positions, so you can see this. It just depends on what area we need to do surgery on. There is potential for injury with any surgery, so we do make sure that we've got proper body positioning, and this is going to include making sure that we don't have a lot of bony prominences. We're trying to make sure that it's protected well with either gel pads or egg foam or a variety of different methodologies, because we're trying to prevent ulcer formation as well as nerve conduction or circulation issues. Anytime we cut into somebody, of course, there's potential for infection, so we try to minimize that using all these things. Put an adhesive drape over, might insert drains so that some of the infectious fluid from inside the body can drain outwards. We'll do skin closure techniques, often sutures is what we're talking about. And then we got to be very careful when we're transferring the patient from the OR stretcher and back and forth. We talked about skin closure devices, so some things that we can do with this would be looking at sutures. We can look at staples. We can talk about stays. We don't use lots of glue and tape anymore. One thing I want you to be aware of is it an interrupted suture or is it a continuous? So interrupted usually take a little bit more time, but they're nice in the fact that if this suture right here breaks, then the rest of them don't. Where on a continuous suture, if this one breaks, then the rest can unravel and cause difficulties that way. We do have to watch for potential for hypoventilation based on the meds that they're giving. So we want to make sure, of course, ABCs, and then notify the provider if there's any difficulties. This concludes this video lecture. If you have any questions,